Our next session on Cancer Screening 101, and it's Cheryl Meguid from UCHealth. Thank you.
Yes. Hi, everybody. Can everybody hear me? Good? Okay. I'm Cheryl Meguid. I'm a nurse practitioner. I've been at the University of Colorado Hospital for the last 13 years. I am very passionate about the multidisciplinary approach to cancer care, and I particularly care for pancreatic cancer patients. This is a great segue because I'll actually be talking about how we use AI for high-risk screening for pancreatic cancer patients. And so just to start with some statistics, cancer is the second leading cause of death globally. There's about 1 in 6 deaths every 6 deaths globally, and 1,700 cancer deaths per day. And in 2025, about 618,000 patients are expected to die from cancer in the United States. The top cancers of deaths in the US, which really haven't changed, lung and bronchus is number 1, colorectal, closely followed behind by pancreatic, breast, and prostate cancer. And so what is cancer screening and why is it important? Cancer screening, simple, testing for cancer in asymptomatic individuals. And why is it important? Because we know that early detection leads to better outcomes. And that early detection also leads to less invasive treatment, and I'll go into that a little bit. And it's also important to reduce cancer mortality. And so before I go into screening, it's important to talk about the Wilson and Jungner criteria, which essentially is a framework to assess whether a screening program is likely to be beneficial. And I've listed all 10 there, but I'm focusing on 4. Condition importance. Obviously, we know cancer screening is important. It's the second leading cause of death. Need to make sure there's a suitable test. Tests must be reliable, valid, and affordable to the population. An example to this would be mammograms. They're typically easily able to be obtained. There should be an effective treatment, and there should be early intervention. So just a couple definitions here. So screening versus diagnostic testing. So when we're screening a patient, we're screening someone who is asymptomatic. When we're doing diagnostic testing, that's when we're testing a patient who has symptoms. There's a lot of benefits to cancer screening, but there are also a lot of harms. Some benefits: early detection saves lives. We know early cancers are curable or highly treatable. Less invasive treatment if a cancer is found early, often treated with localized therapy instead of systemic therapy. There's a reduced disease burden, so there's fewer complications, better quality of life. There's prevention in some cases, like detecting precancerous lesions, and there's peace of mind for patients who undergo screening and have a negative test. But there's also harms. There's false positives, which causes anxiety, stress, more tests. There's false negatives, which causes false reassurances and delayed diagnosis. There's overdiagnosis. This is detecting cancers that never would have caused symptoms or death. And this could be in relation to some prostate cancers or certain thyroid cancers. There's also overtreatment, which is unnecessary treatment for cancers that may have never progressed, and complications from procedures. Rare but bleeding perforation from colonoscopy or infection scarring from biopsies. And there's also important anxiety and costs. Basically, the bottom line is if benefits outweigh the harm, screening is still recommended. So sensitivity versus specificity. This is what's confusing for me. So kind of just to break it down, sensitivity is the probability that the test correctly identifies patients with the disease. So high sensitivity means fewer false negatives. If a test is very sensitive, a negative result will help rule out the disease. Specificity is the probability that the test correctly identifies people without the disease. So high specificity means few false positives. If a test is very specific, a positive result will help rule in the disease. So screening tests typically aim for high sensitivity. They don't want to miss someone with a cancer. Confirmatory tests need high specificity. They need to make sure the patient has a cancer. Some examples: so the FIT test for colon cancer is high sensitivity but less specific, but a colonoscopy is high specificity, and we use that as confirmation for colon cancer. So these are general guidelines for cancer screening. These are not for guidelines for patients who are predisposed to certain cancers or higher risk. So breast cancer, mammography, sometimes patients are recommended to get breast ultrasounds, typically aged 50 to 74, but higher risk individualized age 40 through 49. Cervical cancer, pap smear, and HPV testing typically starts at age of 21, varies with age and test type. Colorectal cancer, colonoscopy is the preferred test. Sometimes patients do not, even my mother did not want to do a bowel prep, and so they decided to do the FIT test or maybe stool DNA. Colonoscopy is the preferred test, and that is now with the new NCCN guidelines starting at age 45. Lung cancer, patients are recommended to get a low-dose CT. That's adults age 50 to 80 with a greater than 20-year PAC history who currently smoke or quit in the last 15 years. Prostate cancer is kind of controversial due to overdiagnosis, but PSA test is recommended. And then pancreatic cancer. Pancreatic cancer is actually now becoming more and more widely accepted for screening, and we actually have a very robust program at the University of Colorado Hospital where we screen patients at risk for pancreatic cancer, and for those patients we do MRI and endoscopic ultrasounds, and this is based on patients having a family history of pancreatic cancer, precancerous cysts, or germline mutations. So where is the future of cancer screening? So genomic screening. So we can do liquid biopsies. These are blood tests that detect circulating tumor DNA or ctDNA. This is the potential to detect cancers before imaging or symptoms. There's also molecular testing on the actual lesion. So we're doing molecular testing on patients with pancreatic cysts. There's multiple tests out there, but it'll tell us basically if this risk is a high-risk lesion or not. They do it for thyroid nodules as well. This is still being validated, though. There's risk of false positives, cost, what to do with findings. Genomic risk profiling, these are identifying patients who have a germline mutation. And so we screen every patient that comes with a family history of pancreatic cancer. We screen them, and it's something along the lines of 88 genes that we're testing them for. And so this identifies patients predisposed to many, many cancers: breast, ovarian, colon, pancreatic, gastric. And so based off of the results of those, we determine a high-risk surveillance program. This requires a referral to a genetic counselor for them to do the testing. And then AI and imaging. This is a perfect segue from the last talk. We actually use EON. It's a program called EON. It's an AI detection on incidental findings based off of the radiology report. So an ultrasound report, CT, MRI, PET. AI will find the wording in the report, and it automatically gets a letter sent to the patient and to the primary care doctor that they have this incidental finding, and it's recommended that they have screening. So we actively have this program for pulmonary nodules, for pancreatic cysts. Thyroid nodules are coming down the line. Liver lesions likely will be coming down the line, but this is really exciting. It identifies patients, who we can prevent developing a pancreatic cancer. The problem is that there's a lot of patients actually that have pancreatic cysts. It's about 50% of the population have pancreatic cysts called IPMNs, and we're identifying them. So it's a huge volume of patients. But it's really great getting patients in early. We're able to screen them, and the goal obviously is to prevent cancer from forming. Personalized screening. So these are risk models that combine age, sex, family history, lifestyle factors, and genetic predisposition. This is exactly what Whitney was talking about with individualized, personalized screening based off of your risk. The more information we know about a patient, the higher risk that they have of developing a certain cancer, we're going to personalize their screening program for them. So take-home points. Cancer screening saves lives, but it's not without risks. We want to focus on evidence-based guideline-supported practices. Screening should be individualized and equitable. And conversation with patients matter just as much as the test. Nurses play a huge role in helping patients understand screening. And so your role is important to walk patients through what you think or what they think is the best screening program for them. I'm probably going to end early, but I'm open for questions. And yeah. Thank you.
What are some of the ways that we're making this testing more equitable?
More equitable? I think I'll take pancreatic cancer, for example. I think we used to not cover, insurance companies used to not cover pancreatic high-risk screening, but as more and more data was found and who should be screened, more and more insurance companies started covering those like MRIs. I mean, I remember having to do 8 years ago, peer-to-peers with insurance companies on so many patients because they had 3 first-degree relatives, but their insurance company didn't believe that they should be screened. And so working with insurance companies to actually cover these exams. And so now pretty much every insurance company covers high-risk screening for pancreatic cancer. It's in the NCCN guidelines now, screening protocols. So it's just, and so for me, I would think that's equitable. I mean, I think you hear about, mammograms, a bus that has a mammogram on it for patients, to get access to, and just really just making sure patients know where these resources are.
Any other questions? Perfect. Okay, thank you so much.
Perfect.